Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to talk about one of the things that I was teaching in Amsterdam a few weeks ago. It is a tibial nerve entrapment that causes numbness on the bottom of the foot and the big toe. And it's not the tarsal tunnel protocol that I've discussed before, where we're looking at entrapment of the plantar nerves before they go into the bottom of the foot. There is an episode about that you can find. This is just about a tibial nerve entrapment just below the popliteal fossa. It gets entrapped by the soleus. The soleus at the top of the soleus, just below the popliteal fossa, about 5 centimeters down, has a very tendinous arch. It is called the tendinous arch of the soleus. And if you can imagine this little hammock-looking tendon that when it gets very tight can compress the tibial nerve goes right under it, deep to that soleus arch. So it creates like a tunnel syndrome of its own. And Dr. Trescott says that is very often a double crush scenario where the soleus arch compresses the tibial nerve enough to increase symptoms of a more distal entrapment, like the tarsal tunnel entrapment of the plantar nerves. So you want to look for both. I've talked before about how a neurogenic thoracic outlet can increase symptoms for something like a cubital tunnel or a radial tunnel. So you want to consider those other entrapments and not only look to the spine. So, and you'll find on seniors that this is really, really common cause of their numbness on the bottom of their foot. And once you start palpating, you'll realize how common it is. And it's my opinion that because it has been going on for a long time, and because of the numbness caused by the tibial nerve entrapment, I think they actually stop feeling much pain from the entrapment. Dr. Trescott will talk about the pain in that area, especially on something like dorsiflexion, or pressing a pedal like a gas pedal. And I think that's when it's a fairly new issue. I believe when it's been going on for a decade or maybe more, they may not be aware of that entrapment pain anymore. Because as you know, when nerves get entrapped, sensory nerves get entrapped and irritated, they put out more of the pain chemicals that irritate the area, which is how palpation helps us find the entrapment zones. So you have a tibial nerve that comes down. It splits just above the knee. The sciatic nerve will split between to become the tibial nerve that goes down the back and the common peroneal nerve that will divide just before it wraps around to the front of the low leg, around the fibula. So the the tibial nerve right below the knee, it goes straight down, and there's an artery there too, which is just something to consider. It's why when I talk a little bit about where I like to treat, there are some precautions. Um, it's it's hard to puncture a vessel with an acupuncture needle, especially if it's about 32 gauge or thinner. So it's not a huge risk of creating some sort of hematoma, but how about let's not? Um, it's just nicer for the patient not to have hematomas or bruises. So, so the soleus gets very tight on a lot of people, especially people who have had a history of an L5 issue, L5S1. They're going to have more, or even L4, L5, but that low lumbar area uh, is going to be more prone to muscle shortening if there's a history of lumbar compression. And I don't know about you, but I'm pretty sure most of us who have made it past 40 years old have some amount of degeneration in that area that's going to put pressure on the nerves, even if it's not causing, radiculopathy, weakness, etc. There is enough pressure there that there's more uh, acetylcholine going out just to get the job done. And the acetylcholine can irritate muscles and make the muscle cells depolarize and shorten. So it's just pretty obvious with age and use. And remember that the soleus just almost never fatigues. The soleus has to hold us up and keep us from falling forward on our face. So it's constantly working. And that means it's prone to becoming really, really tight. And I would suggest, and I don't have cadaver studies to say so, but there's I think it's one of the more dense fibrotic muscles, based on the feel I get when I needle it on someone who has extreme ischemia in their low leg. Um, so the soleus, and we do know from cadaver studies that when there is a tibial nerve entrapment, they've done MRIs and they've done cadaver studies, and what they see is a flattening of the tibial nerve under that arch of the soleus, as well as more fibrotic arch of the soleus. So it's possibly a sort of vicious cycle. Nerve compression, muscle shortening, nerve compression, fibrosis, makes it a little tricky. Now, does that mean we can't treat it with motor points? No. I have not needed to dry needle the arch of the soleus. I have been able to get excellent results by just stimulating the motor point of the soleus. And I'm going to give you a couple because I like two. I like two of them a lot. And you can do this with the patient prone and put a bolster under their ankles for comfort. So what I like to do, and this is like how I would like to start a foot neuropathy treatment. I start with the patient prone and treat the soleus, maybe the gastrocs too, just for circulation, but the nerve entrapment soleus. And then when they're face up, we do more of the tarsal tunnel stuff and the superficial peroneal nerve entrapments and all that stuff that I've already talked about in other episodes. So while the patient is face down, you start palpation. I mean, you've already palpated to confirm some soreness about 5 centimeters below the popliteal fossa. You know that there's an entrapment, but our needles aren't going to go there. They're a little farther down, more distal, below the midway point of the calf. So you start by palpating the Achilles tendon way down near the heel or the ankle. You grasp the Achilles tendon and you walk your way up with it all the way up to about a third of the way up. So the Pareto guidance is that you're going to needle um, right where the gastroc tendon joins the Achilles tendon. And it's going to be on the medial side of the Achilles tendon. So you palpate and you walk your way up. You find a nice spot um, where the Achilles is joining in to that shared tendon of the soleus and the gastroc that becomes the Achilles tendon. And then you're going to put your needle pretty much straight toward the table. I don't think you should angle in too much just because you're close to the tibial nerve. There's an artery in the back there. I mean, you're not going to go that deep, but you do want to push with your finger, your palpating finger, to feel the density of the soleus, and that's where your needle's going to go. Sometimes you'll find with orthopedic needling that just tapping the needle at the surface of the skin and then pushing your needle in is not very accurate. And we don't use ultrasound guidance in acupuncture. So what we use is our hand. And what you're going to do is you're going to push to compress the gastroc enough that your index finger is touching the density of the soleus, and then you put your tube and your needle next to that palpating finger and you tap your needle and you insert it slowly to not create too much of a twitch. If there is going to be one, you go slowly into that dense muscle, and then you're spot on where you want it to be without just hoping you were angling in the right direction. Pushing to the depth that your needle needs to be is the best, most accurate way to needle a muscle that's more deep than just the superficial area. So you put that one in, and then the one that I just learned from Jenny Nieters, she's Dr. Jenny Nieters is in California. She works for the pro football team there, the San Francisco 49ers. And she's an awesome teacher. And she was, this is the second time we taught together in Amsterdam. And she did a course about the ankle and the Achilles. And she showed us an excellent motor point that seems to be right around bladder 57 in Chinese acupuncture. And you find that for those of you who are listening who maybe do not study traditional Chinese acupuncture, you're going to follow the Achilles straight up to basically where the two gastroc heads meet and create like an inverted heart shape. There's just like a little triangle there. And it's an excellent motor point for the soleus. The caveat being that you're just superficial to the tibial nerve and artery. So you don't go deep. You don't needle it deep. You don't need to needle it deep. A centimeter seems to be about where I put the needle, about a centimeter in, and you get a really nice movement of the soleus. So I would recommend trying that one. And like I said, just don't go too deep. It works great. I love that spot. I have never seen that used as a motor point before. I think it might be Whitfield Reeves who originally started using that point as a motor point for the soleus. I'm not sure. Jenny has studied many years with Whitfield and now teaches her own orthopedic acupuncture courses. I'll put a link in the podcast episode description if I can find some of her courses so you can check her out, especially if you're on the West Coast. So those are the 2 points that I like to use. Those are awesome. And you hook them up for about 10 minutes, 1 hertz, just enough to move everything. You don't need to do it too strong. And that's where I like to start. And I have had such good results by treating foot neuropathies as nerve entrapments and ischemia. I mentioned a patient where just within a few sessions. I mean, actually, after her first session, she was starting to feel her feet, but then we got picky because there were little areas that were still numb, like the ball of her foot on one side. And I decided to treat that as just an ischemia because the ball of the foot doesn't really follow a nerve distribution, a sensory nerve distribution like the medial plantar nerve. So I decided to treat the flexor digitorum longus and brevis. And sure enough, when she was after we scheduled her next visit and she was walking to the door, she turned around and said, "It's better." Which is great. Like I love instant results, especially for something I don't expect instant results on, like neuropathy, because it usually takes a day or two to kind of get the blood circulating and get the nerve to calm down and or the nerve to start feeling something. So I love that. And so I've had really good results with this approach, treating nerve entrapments and ischemia for foot neuropathies. Um, so I guess that's the gist of today's episode. The next episode, I'm going to talk about the other stuff that I was teaching in Amsterdam, like what is the radial tunnel? How does it cause pain on a motor nerve? Um, what are we looking for when it's creating a weakness in wrist extension, like the palsy, as the posterior interosseous nerve entrapment. And then what are we looking for the sensory part of the radial nerve? Where's the pathway, and what are the muscles that would cause that numbness of the dorsal part of the hand and thumb? So that's next week. Have a great week. And I will, look for the information in the description for this episode for Dr. Jenny Nieters Courses in California. All right, take care.